Hello, 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 ladies and gentlemen. This is the 10-minute lecture for the mini lecture for upper airway disorders. That's what we are talking about this evening. So, we are thinking about medications, and we're thinking about medications for rhinitis. So please remember that sedation, performance impairment, and anticholinergic effects such as dry mouth and dry eyes, constipation, and increased heart rate are common side effects of these first-generation antihistamines. And one of the more common antihistamines that are first generation is diphenhydramine or Benadryl. There are going to be first generation antihistamines and second generation antihistamines, and the difference, is going to be sedation. One is going to be sedation causing, and the other is not. And then anticholinergic effects, they are just very drying to the body. So, second generation over the counter antihistamines, such as Claritin, Allegra, Zyrtec, will have less or no tendency to cause sedation. Intranasal corticosteroids are the most effective treatment for allergic rhinitis and related symptoms when they are used on a regular basis. However, there is no systemic effect from the use of intranasal corticosteroid medications. So these medications, these intranasal corticosteroids, are going to take longer. They may take days or weeks for the patient to have full symptom relief because their effects are not systemic. Intranasal sprays that contain antihistamines, however, can result in a systemic antihistamine effect. Ladies and gentlemen, Table 25.1, medications that are used in the treatment of rhinitis. Please know that table. Please take a look at that table. It's an important table. Decongestant nasal sprays, such as Afrin, should only be used for a few days at a time, as overuse may cause rebound congestion. Rebound congestion is severe congestion. And so I know that the PowerPoint, says not to be used daily. However, the patient may use Afrin nasal spray daily. However, 3 to 4 days max. So because it is 3 to 4 days max, I always try and instruct the patient to stop using it after day number 3, because most people, if you tell them, oh, you can only use this for 3 days, many of them will push it to day number 4, which is really should be the max. So it is really 3 to 4 day max for Afrin nasal spray. So some of those common medications that are used for rhinitis, diphenhydramine. Again, diphenhydramine is the generic name for Benadryl. It is a first-generation antihistamine. Guaifenesin is the generic name for Mucinex, and that is a very common decongestant. And then fluticasone is the generic name for Flonase, and that is the preferred corticosteroid nasal spray. So, ladies and gentlemen, patient education for rhinitis. We need to teach the patient about the appropriate use of these medications, and also to avoid nasal decongestant use for greater than 2 to 3 days at a time due to the risk of that rebound congestion, that severe congestion. We also need to instruct the patient to complete antibiotic therapy as prescribed to avoid those super infections of the creation of antibiotic drug resistance. So that, ladies and gentlemen, means that that patient needs to complete the course of the antibiotic. They can't just take the antibiotic until their symptoms begin to resolve. They need to complete the course. Excuse me. So rhinosinusitis. Rhinosinusitis, please remember, is that all encompassing term. It is no longer rhinitis, which is only the nasal passages. Rhinosinusitis is going to combine the nasal passages and those sinus cavities, those 4 sinus cavities. And please remember that rhinosinusitis is more common in females. The presence of nasal polyps will be seen in almost 50% of patients. So nasal polyps would be considered a risk factor. So, ladies and gentlemen, obstructive sleep apnea. Some risk factors will include the male gender, obesity, being overweight, cigarette smoking, alcohol use, if you are between the ages of 40 and 65, and if you are a female, if you are in menopause. Again, insulin resistance is also associated with the severity of obstructive sleep apnea. So, ladies and gentlemen, laryngitis. Laryngitis. So, when we are thinking about laryngitis, one of the things that I want you to think about is stridor. Stridor is that medical emergency. It is that high pitched wheezing breath sound that is caused by turbulent airflow in a partially obstructed larynx. It is a medical emergency because there is an airflow obstruction. So, ladies and gentlemen, one of the times that it is very common for us to see stridor is after the patient is being, or when the patient is being extubated, because it is that endotracheal tube that is going to be holding that airway open. So once that airway is, once that endotracheal tube, which is holding the airway open, is removed, if there is swelling or if there is still trauma present or if there is edema still in that neck area, once we remove that endotracheal tube, that airway is going to close. And what we will be hearing as the patient takes their first breath is going to be that sharp intake of air, that stridor, which is going to tell us that that endotracheal tube needs to go back in because that airway is at least partially obstructed. Now, because of the swelling, because of the trauma, because of the edema, there may be times when we cannot, whoever is tubing the patient, placing that tube, whether it's the respiratory therapist or the physician, they cannot get the tube back in which case doctor may have to perform a tracheostomy to give the patient an airway. So, ladies and gentlemen, it is going to be your responsibility, the nursing responsibility, to have emergency airway equipment readily available at the bedside because that hoarseness and stridor post-extubation may indicate acute obstruction of the airway. That is a medical emergency. And so, again, if we cannot get that endotracheal tube back into the patient to give them an airway, doctor is going to have to perform a tracheostomy. So, ladies and gentlemen, when we are talking about surgical management of laryngeal cancer, the total laryngectomy is going to be the complete removal of the larynx, the voice box. In advanced stages where the cancer has spread beyond the vocal cords, it can be a curative procedure. The larynx and several rings of the trachea will be removed. Swallowing ability will remain, so my patient will be able to eat, they will be able to drink. Normally, swallowing ability will remain, but there will be no speech. The patient will not be able to speak. So therefore, the patient needs to know this going into the surgery, that yes, they'll be able to eat, yes, they'll be able to drink, but they will not be able to speak. So going into this surgery, we are going to have to devise a plan for how this patient is going to communicate post-surgery. We can't wait until they wake up and say, oh, okay, how are we going to get this patient to talk to us? No, it has to be decided before the surgery. And then creation of a tracheostomy will be required for breathing and because of the risk of aspiration of fluids and food after doctor removes the epiglottis. So, ladies and gentlemen, smoking cessation. There are some medications that we can use for smoking cessation. The first line is going to be nicotine replacement therapies, including nicotine gum, nicotine patches, and then those lozenges. And then there are some non-nicotine therapies such as Chantix, Zyban, and then second line medications are clonidine and nortriptyline. So, ladies and gentlemen, some nursing interventions for laryngeal cancer. We are going to think about instituting aspiration precautions. Postoperatively, the patient is going to be at risk for aspiration because of removal of the upper airway structures and the epiglottis. And then please remember that we need to provide the patient with the means for communication because post-laryngectomy, this patient will not be able to speak due to the removal of the larynx. So, pen and paper, a communication board, a cell phone, some way that they need to communicate. And then nutritional consultation and then calorie count because this patient will need to heal and recover. So small, frequent meals throughout the day instead of 3 larger meals. So, ladies and gentlemen, radiation therapy for laryngeal cancer. The patient is going through radiation therapy. One of the things that we want to remind them of is to use a soft bristle toothbrush and to brush and floss after each meal and again at bedtime. Now, if the patient is going through chemotherapy for laryngeal cancer, the nurse may have a larger responsibility. So the nurse is going to be responsible for monitoring fluid, and electrolyte balance, their weight, intake and output, and we are going to encourage intake of fluids and frequent small meals, not those large meals, but those frequent small meals. It's more comfortable for the patient and they're able to take in just as many calories, or if not more, with a small frequent meal. The nurse will also monitor the patient's white blood cell count for signs of neutropenia, because if the patient is neutropenic, below 2 traditionally, chances are that they will not be able to receive their chemotherapy that day. And we also need to monitor the platelet count for signs of thrombocytopenia. If the patient has a decrease in either count, the patient will be placed on neutropenic precautions for a WBC count less than 2, or bleeding precautions depending on the platelet count. So patients are encouraged to avoid crowds and persons with infections and instructed to report increases in bruising, blood in the urine or the stool, or if they have increased fatigue. This is not a person that can be around many people, a lot of people. They should not be. So, ladies and gentlemen, when we are talking about clinical manifestations of laryngeal trauma, we have to remember that the airway can become obstructed from edema or from the fracture of the laryngeal structure, or if there is a hematoma present. So, management of laryngeal trauma. Diagnosis is completed by conducting a physical inspection of the neck for signs of swelling, discoloration, subcutaneous emphysema, tracheal deviation, or that open wound. And again, ladies and gentlemen, please remember that priority of care is going to be the insurance and the maintenance, of that airway. The patient will need a patent airway. So maintenance of the airway may include endotracheal intubation or that tracheostomy. So please remember that nothing happens with that patient. That patient does not go for testing. That patient does not go for diagnostics until that airway is patent and that cervical area is patent and intact. The patient may have a change in quality and character of the voice or hoarseness, difficulty swallowing, or difficulty breathing, and then discoloration and edema of the neck will increase the suspicion of laryngeal trauma. So some nursing interventions for laryngeal trauma. Some nursing actions would be to have that tracheostomy insertion tray and emergency equipment at the bedside, because this is somebody who is at risk for losing that airway. The patient may have a sudden loss of the airway requiring an emergency tracheostomy, and we will provide humidified air via the face mask or a face tent if it is necessary. And please remember that this humidified air is always cool. It is never warm, because we want to decrease this airway edema. So, ladies and gentlemen, if this is a patient that seems it is fine for them to go home, we're going to have to do some patient education after this laryngeal trauma. So what we're going to have to do is what we are going to stress to the patient and to the family members is symptoms to report to the healthcare provider and when to seek emergency medical care, when to come back, because a compromise in the airway patency can quickly progress to airway occlusion, and then the patient may pass away. So they need very, very good patient education as to what to look for. Maybe one of the things that you want to tell them to look for is that voice becoming very, very hoarse as if they are straining to talk, or if they begin to hear that stridor.